Dr. Raghav, Preetam.
Ankit Agarwal is here.
And perhaps it's a good idea to make sure that the next one is also available.
Preetam.
Yes, the first one.
Good morning, everyone. At the outset, I would like to thank AIOC for giving me the opportunity. Today, I would be talking about Amantadine keratopathy. Is it a myth or reality? Let's look at a case of a 62-year-old lady came with blurring of vision for 4 months, which was painless and sudden in onset. She had occasional watering and foreign body sensation. She is a known Parkinson's disease patient with CKD and dyskinesia as well. She has been using Amantadine 100 milligrams BD for the past 15 years, along with carbidopa, levodopa, and entacapone. Past ocular history, she's visited 3 ophthalmologists before me, including 1 cornea surgeon. She was treated with repeated doses of steroid, Rho kinases like netarsudil and sodium chloride for the past 2 months. Both eyes were planned for endothelial, both eyes were diagnosed as endothelial dystrophy and planned for a transplant. This is on presentation. The vision in both eyes was around 20/100. Patient had DM folds with altered anterior corneal reflex with stromal edema. IOP was within normal limits. This is the anterior segment OCT, which showed increased pachymetry in both eyes with a wavy pattern of DM posteriorly with altered stromal reflectivity. Differentials at this point of time were herpes disciform keratitis, but it was not so because of the absence of cellularity in the stroma. There were no KPs on the endothelium as well or previous scars. Fuchs was also ruled out because in the periphery where the cornea was clear, we couldn't see any beaten bronze appearance or we couldn't see any of the guttae. It was completely non-inflammatory, so all the inflammatory causes were ruled out, which shortlisted the diagnosis probably due to drug-induced keratopathy. Because it's a very rare diagnosis, I went through literature and we could find 21 cases overall, and we tried to match the demographics and the profile to the case. So it is more common in female, like in our case, of age around 50 to 60, more common with Parkinson's disease, who are using Amantadine for dosage of 100 milligrams per day. So I wrote a letter to the neurologist asking him to stop Amantadine. Thankfully, he stopped and switched it to pramipexazole. Topically, I started the patient on prednisolone acetate 4 times a day along with lubricating drops. As you can see, on day 10 of stopping Amantadine, the posterior corneal edema is slowly coming down. However, the anterior corneal edema with few bullae are still persistent. By day 45, the cornea became more compact. Only mild anterior corneal irregularity persisted, and the vision improved as well. And by day 75, the cornea became clear. There was NO4 grade cataract. With refraction, the patient was improving up to 6/9 vision in both eyes. So what are the unique features of my case? So this is the longest lag time from the initiation of therapy. In literature, the other longest case was 10 years. We have 15 years, which documentation you can see on the right side where she started at around 2013. And there is complete reversal. The last case in literature, which had more than 10 years, had to go transplant. Despite having coexisting kidney diseases and such long lag time, presentation is also very rare and also presented with near bilateral symmetrical corneal edema at presentation. Thank you.
So how did you treat this case?
So, to start with, I asked the neurologist to stop the medication. The Amantadine stopped and I just gave patient symptomatic relief with lubricants and topical steroid because of the surface inflammation. I tapered down the steroid. As the drug washed off from her system, the cornea improved on its own.
Became clear totally?
It became completely clear, yes. Otherwise, the patient was already planned for a transplant as well. Just by stopping the drug, the cornea came back to completely normal state.
Great, nice case.
Nice presentation. So, is it a myth or reality?
Reality for who believe in it. Myth,
So people like me who don't know encounter
because
this.
because I get this a lot, because I don't have a way to prove it, in the sense that I don't have a diagnostic test to say that amantadine actually caused the corneal edema.
What about
So the
literature
speculation
search?
will always be there.
What about literature search?
Literature search, there are around 20 cases overall in the world, and they have similar kind of presentation, and the demographic status is similar. The amount of amantadine taken, the vision dropped to 20/100. So there are similarities which match the literature which has already been published.
And what are the other side effects of amantadine that are documented?
Amantadine related retinal toxicity
Not
has
just
also.
retina, overall in the body.
So it can lead to kidney disease as well. So this patient was having the chronic kidney disease. Despite that, neurologist wanted to persist with the treatment because it was working for him. And what happened immediately after stopping amantadine as well, the patient started having more movements. They were even more worried, saying that you asked us to stop the treatment, now my movements are getting worse, I can't see. But I just reassured them, saying that this is the way of treatment. Slowly with pramipexazole, she could cope up with her daily activities, and corneas improved, so they gained more confidence.
And is it maintained? The corneal clarity
It is completely maintained. The clarity is maintained, and we have planned her for a cataract surgery.
That is good enough reason to say it's reality then.
Thank you.
Thank you.